Good morning or afternoon. It's a pleasure to join you once again in Korea and take part in your outstanding meeting on prostate cancer. I look forward to participating with you once again in person next year. We will keep on trying. I hope you have a great meeting. My talk this time is on focal therapy, and the question is focal therapy a standard of care treatment for prostate cancer? This is a very controversial topic, and I will give you at least my opinions based on fact and also some speculation for the future. So the premise is that focal therapy is the standard of care for intermediate risk patients with a unilateral or focal clinically significant lesion on MRI or a biopsy. Why? The index tumor is thought to be the only significant tumor within the prostate. The idea is that it can be visualized, and if it can be visualized, it can be mapped, and if it can be mapped, it can be ablated with minimal side effects compared to radical therapy. And of course, patients do want it. So effective focal therapy requires answers to numerous questions just to be able to get it right. So the first question, which I'll focus on quite a bit, is who to treat. Should we be treating only intermediate risk cancer? Should we treat just solitary lesions, or is unilateral cancer involving, let's say, more than one lesion sufficient? What about the tumor size? Is there a size limit? How about location, periphery, central? How close to the urethra, etc. Where do we treat? Do we treat focally, or do we use hemiablation, or do we even go across to the other side and do three-quarter ablation, preserving only essentially the tissue around the neurovascular bundle on one side? What's the proper energy? HIFU, cryotherapy, laser frequency ablation, photoablation, irreversible electroporation, or IRE. Many energies, little evidence to support one versus the other. How do we monitor patients after focal therapy? What's the best way? Do we use PSA? What are the thresholds? Do we use biopsy? How often and how? Do we use imaging, MRI, or PSMA? How do we define failure? Is it based on biopsy, and biopsy in particular detecting a significant cancer? Is it based on MRI, a lesion that didn't go away or that starts to grow? Can we use PSA to define failure as we do with radiation and with surgery? What are the acceptable outcomes? Does focal therapy need to meet the same standards as radical therapy, that is cancer control? Is delaying the need for radical therapy an acceptable outcome? And if so, what are the trade-offs? And what is the impact, short or long-term quality of life, and what are acceptable outcomes? So the first question is who to treat, and can we identify the optimal candidate? I'm going to focus really primarily on, can MRI identify the optimal candidate to treat, and together, of course, with biopsy, targeted and systematic. So these are the questions. Can MRI identify and localize all significant tumors? Can MRI delineate the extent of the tumor so that the treatment can be selected and treatment planning done in order to obtain a successful ablation? Can MRI tell us whether a patient has unilateral versus bilateral tumor? Can it tell us the accurate tumor volume? Can it tell us with accuracy how close the tumor is to the urethra? So this is a paper that I've shared before. This is from a very large series of men who underwent MRI prior to surgery, and we looked at the sensitivity of MRI for detecting all lesions. This is important because if we are going to rely on MRI, particularly to identify patients who are optimal for focal therapy, then we need to know the true sensitivity of MRI, not just for the index lesion, but for all lesions. And as shown here, MRI does very well, but it's not perfect. It misses about 20% of solitary or index lesions and can miss as many as 40% of Gleason grade 7, 3+4 tumors. Therefore, one probably cannot rely exclusively on MRI to identify or select the appropriate patient, and this needs to be considered together with biopsy. How about targeted and systematic biopsies? I think that this helps us, but I think the fact that targeted biopsy does not detect all lesions is consistent with our MRI data. And indeed, a recent paper from the group at the National Cancer Institute stated very clearly that targeted biopsy alone will miss upwards of 20% of patients with significant cancer, and that one must combine systematic and targeted biopsies. This is a paper from our group that looked at the concordance rate between targeted and systematic biopsy. That is, did they find the same things? And we showed that a significant percentage, as many as 20 to 30% of men, the targeted and systematic biopsies are identifying significant cancer in different locations. So one needs to do, at a minimum, systematic and targeted biopsies to identify appropriate patients for focal therapy. So we went back and we did a retrospective look to see whether or not systematic and targeted biopsy could actually do a good job in identifying patients who were optimal candidates for hemiablation. We used, as I'll show on the next slide, accepted criteria by a group of focal therapy experts who sat together and decided who was the appropriate patient. And so we looked at those criteria. We identified, as you'll see, 92 patients who met those criteria. And then we went back and looked at their whole mounts, and we asked whether those patients who met MRI and biopsy criteria for hemiablation, when looking at their radical prostatectomy specimen, would actually have been the optimal candidates. If that number was 100%, then by all means we can use MRI and biopsy to select patients, but if it's not, we need to be careful. And we perform many sensitivity analyses to make sure that that we couldn't improve upon our data. These were the eligibility criteria: clinical stage T2, serum PSA less than 20, a clear region of interest on MRI, significant cancer defined as 4+3 or less, and all lesions had to be on the same side, that is targeted and systematic biopsies. And what we found is that unfortunately, in 48% of patients who we thought would be optimal candidates for hemiablation based on systematic and targeted biopsy and MRI, they actually probably were not good candidates. 41 patients had a discordant laterality of clinically significant prostate cancer, that is, cancer on the other side of the prostate. In other words, away from, on the other side from the supposed unilateral cancer detected by biopsy and MRI. 21 cases, the tumor crossed over the midline, and 20 had an undetected distinct contralateral tumor, and 3 had ipsilateral upgrading to 4+3 with tertiary pattern 5, Gleason score 4+4 and 4+5. Causes of discordance on whole mount, as I showed, were a crossover from one side to the other, as well as distinct secondary tumors on the contralateral side. And we also looked at the locations of these, and one thing we did show is that tumors located in the peripheral zone did cross over less frequently than tumors in the central zone. So that does suggest one anatomic piece of information that we might use to help select patients for focal therapy, and I'll come back to that later. And this is a typical case where there's a discordance between the whole mount and the MRI and biopsy. The biopsy showed a lesion only on the left side, as is seen at where the MRI lesion was positive, and one can see that the patient had an unidentified and undetected significant cancer in the anterior zone of the contralateral side, which probably simply wasn't picked up because we don't routinely do anterior biopsies on the systematic biopsy. We used some newer three-dimensional software to see whether we could improve in detecting patients, for instance, who had some crossover to the other side, as shown here. And when we did this, we did improve upon our ability to select patients somewhat. Yet still 42% of patients who we thought would be good candidates, even after excluding those that we took out using 3D renderings, only 42% were still thought to be 58% still were thought to be good candidates, and 42% would not have been good candidates. So we need to do a better job in terms of determining who is a good candidate for focal therapy. The next question is, let's say we pick the person perfectly. Where do we treat? Can we identify the target adequately so that we can completely ablate that lesion? So this is a problem that we have addressed over a number of years. This is the extreme example of a case where the MRI detects a small lesion. The targeted biopsy detects a small lesion, but on the whole mount, the tumor is quite a lot bigger. And note that it's not circumferentially enlarged around the target, but is somewhat aberrant in terms of its extension. Prostate cancers are not nice round tumors. They are in all shapes and sizes. And it has been demonstrated by us and other groups that MRI consistently underestimates the size of a tumor. So then the question is, even if it underestimates the size, can we still use the MRI information to estimate tumor volume and plan treatment? This is a study that we just published this past year. And what we did is we looked at over 500 patients, comparing their MRIs to their radical prostatectomy whole mounts. And we looked at the difference between the radiologic tumor size and the pathological tumor size. And as can be seen here, there was a great deal of variability. The y-axis is the pathologic minus the radiologic size, and we compare that to the radiologic size. If the world was perfect, that would be 1. If it was very predictable, it might be some ratio, but still you would expect a straight line. However, one can see is that that's not the case. And the deviation from 1 is greatest the smaller the tumor is on MRI. So that is, the smaller the tumor is on MRI, the greater the difference between the pathologic tumor size and the radiologic tumor size. Generally speaking, the pathologic tumor size being significantly larger. And this is shown again here in this figure, where on the left we looked basically based on the radiologic tumor size. We looked at what the mean difference was between the pathologic and radiologic tumor size. So if the radiologic tumor size was less than 1 centimeter, then the mean difference between pathology and radiology was 1.25 centimeters, as one can see here, whereas larger tumors on MRI tended to actually be more predictive of actual tumor size, with a mean difference of only 0.3 centimeters. But if one assumes that smaller tumors on MRI are the best ones for focal therapy, then one has the problem of how do you use MRI to predict optimal tumor ablation. And although many centers recommend drawing essentially a circle around the MRI lesion, as I showed in the other figure, and from most of our data, this still would not cover the majority of patients because there's such variability in terms of the difference between the radiologic and actual pathologic tumor size. Another question is, can we predict who has tumor very close to the urethra? During cryotherapy or HIFU, one needs to either cool or heat the urethra to protect the urethral lining. And obviously that creates a temperature sink around the urethra. And so tumors that are very close to the urethra might not be easily ablated. To demonstrate this, there were quite a few papers published using radical prostatectomy specimens years ago that showed that as many as 60% of prostate cancers were within 5 millimeters of the urethra, and that those patients who had tumors close to the urethra actually had more aggressive disease with more recurrences, perhaps because they had larger tumors. There's only one study looking at the ability of MRI to predict the distance from the tumor to the urethra, with the goal of determining who's best for focal therapy, and that was done at NYU. And what one can see here is that the area under the curve is quite poor for MRI predicting distance between the tumor and urethra. We are now looking at this more closely, and hopefully I will have data on this next year, but this is something to keep in mind. One thing that one can say is that tumors that are very peripheral are generally less likely to be the closest to the urethra, whereas more central ones are more likely to be close, and I'll come back to that theme again. So can MRI be used to guide focal therapy, that is MRI and biopsy? Yes, the answer is yes. It can certainly aid in patient selection and planning, but MRI can miss 20 to 30% of significant multifocal tumors. MRI targeted and systematic biopsy miscategorize nearly 50% of patients as candidates for focal therapy when they are probably not. MRI underestimates prostate volume with poor correlation between radiologic and pathologic tumor size and performs worst in smaller MRI lesions. And finally, MRI may not predict the distance of the tumor from the urethra. So now, how do we define success? What are the trade-offs that we make? So the results, as you can imagine, are dependent on the definition of failure that we use. This is true for surgery, radiation, and it's true of focal therapy. So here are some of the definitions that are being used in the literature. The most common definition that is being used is radical treatment-free survival. That is the percentage of patients who do not need radical radiation or radical surgery at some point after treatment. Another one is the focal retreatment-free survival. That is failure from the need to have an area that was ablated again. Another definition is biochemical recurrence, using some of the radiation definitions, such as the Astro definition, which is nadir plus 2, or the Stuttgart definition, which is nadir plus 1.2. The other term used to determine success is biopsy. In-field or out-of-field recurrences, how many recurrences, how many biopsies need to be done, however, how often must they be done, and how sensitive are biopsies for detecting. But this is probably the most stringent definition of success, biopsy-free, biopsy cancer-free survival after focal therapy. And I'll look at this more closely. And then finally, can we use imaging, MRI or PSMA, to detect failures? But what one can see here is that we need to come to agreement, and that papers that report radical treatment-free survival but not biopsy-free cancer on biopsy-free survival are really reporting very different things. And it becomes impossible to compare papers or series and make determinations about focal therapy unless we use similar definitions, as we do after surgery. So here are some data that basically bring this point forward. So the group in London, led by Hash Ahmed and Mark Emberton and others, have done a large amount of work on focal therapy, both cryotherapy as well as HIFU. But what's critical to looking at their data is that the common definition that they use for freedom-free survival is freedom from radical salvage therapy or freedom from systemic therapy. They do look at functional outcomes, and this is just one of their many papers looking at intermediate and high-grade patients who underwent hemiablation. The choice was informed by transperineal mapping biopsy in men who had a positive MRI unilaterally. I do think mapping biopsy is better than systematic biopsy because it really does sample the entire gland, and I think is probably mandatory to optimally choose patients right now, given what I just showed you. But if one looks at the failure-free survival rates, they look amazing. Look on the top left, failure-free survival defined as freedom from needing radical therapy was 90% or higher. 85% for high-risk cancer and 93% for intermediate-risk cancer. That's better than surgery. That's better than radical therapy. So again, one needs to look at these as the definitions. But the problem is that in this study, only 29 out of 122 patients actually underwent a biopsy as part of their follow-up. And 21 of those 29 had significant cancer on their biopsy. But again, that was not used in their definition of failure, only the freedom from radical therapy or the freedom from a need for repeat cryotherapy or HIFU. So the question is, are these definitions valid? And if they are valid, perhaps we need to wait much longer to determine their validity. This is a very good paper from the group in France, led by Rafael Torino Barbosa and others, where they looked at 309 men who had unilateral prostate cancer. They only treated low and intermediate risk cancer, and failure was defined in a number of ways. It was defined as local, the need for local or systemic salvage. It was defined based on positive biopsy of a grade 2 or higher lesion, both in-field and out-of-field. And they followed up patients every 6 months. Everybody had to have a biopsy at 6 months. And then there were 4 caused biopsies based on an abnormal MRI or two consecutive PSA rises. And they had a mean 5-year follow-up. And this study really demonstrates the problem. Depending on the definition that one uses, the success rates are different. So if one uses a definition, a composite definition where biopsy is included, as well as freedom from radical therapy and freedom from needing a secondary treatment, on the upper right-hand side, you can see that the failure-free survival for Gleason 7 cancer is at 5 years is only about 30 to 40%. If one looks in the first 1 to 2 years, the data looks fantastic, not too dissimilar from the data from London and other sites. But when one goes out to 5 years and using a complete definition of failure that includes all of the above, the data does not look as good. If one looks at radical treatment-free survival, things are certainly somewhat better, particularly early on. Another question is, even if one uses biopsy, how accurate is biopsy? If one ablates 90% of a tumor, then obviously detecting residual tumor should be harder, even if the total size of that site shrinks because involutes because of fibrosis after therapy. So even biopsy may not completely accurately measure the presence or absence of a residual cancer, but it right now is certainly the best metric that we have. This is another paper from Lori Klotz's group and others in Toronto, where they looked at patients after HIFU. This was again partial gland ablation. And they actually did do biopsies in a significant percentage of men at a mean of 2 years after surgery, after focal therapy. And what they showed is that 42% of patients had residual clinically significant prostate cancer. That is a total of 37 patients. 19 were in-field and 18 out-of-field. One thing that they did show, which is on the upper right, which is interesting, is that the likelihood of a positive biopsy was lower in patients who had a tumor in the periphery. So those patients had a higher recurrence-free survival than those who had more centrally located tumors, which is consistent with other data that I've shown in this talk. But again, this points out that using a more stringent measure of quote-unquote success, the outcomes are not as good as one might anticipate. But if one uses the least stringent definition, or most, depending on how you look at it, of radical treatment-free survival, the data does look excellent. This is a case of mine, a patient who had laser ablation of the lesion seen here on the right, but he had a recurrence that was detected by biopsy, and at the time of surgery, you can see he had an area that was ablated locally, but he had a large amount of residual cancer that was not diagnosed at the beginning. This patient probably was not a good candidate for focal therapy. So getting to the final slide. So are there trade-offs to focal therapy? I think that the key to discussions with patients about the different options for treatment is that we need to discuss what the trade-offs are. No treatment is perfect. There is always a trade-off between side effects and cancer survival, I don't think there's any perfect treatment, including focal therapy. So here are the trade-offs that I always discuss. Yes, focal therapy is less invasive. It does result in a better quality of life. I think this is proven, but the long-term benefit is unknown. So for a young person with Gleason 7 disease, I am less likely to recommend it than somebody who's in their 70s. More invasive treatment, however, of course, has potentially worse quality of life outcomes, even though there's a known benefit. So that's a trade-off that needs to be discussed. So the question is, what's an acceptable outcome? Should we expect the same cancer outcomes for focal therapy as we do for radical therapy? I don't think we necessarily need to make focal therapy an acceptable option. One of the questions, does initial focal therapy with a delayed radical prostatectomy or radiation, does that carry an increased risk either in terms of disease-specific survival or quality of life? Does upfront radical treatment have better success and quality of life outcomes than at a more advanced stage? This is something I tell patients, that if they do surgery now, their likelihood of a good outcome is higher, in my experience, than if they have surgery after one or more treatments by focal therapy because of scarring. We also have to be honest about our own results with radical therapy. At UCLA, we are doing very well in terms of continence and potency. It is certainly not perfect. It would be better with focal therapy. However, it is not as bad as many of my colleagues say who are trying to convince patients to undergo focal therapy. So conclusions, focal therapy is highly desirable, but so far, in my opinion, it is not a standard of care treatment for intermediate grade tumors with a solitary lesion on MRI, because MRI and systematic biopsy are not sensitive enough to accurately identify all men with unilateral cancers. MRI cannot accurately localize tumors to plan the extent of therapy. Ablative techniques have not been shown to have long-term efficacy by biopsy or PSA criteria. And validated ways to measure success have yet to be determined. My caution is that time and definitions matter. 1 to 3 year follow-up data is simply not adequate. 5 to 10 year data is required, similar to what we have expected of radiation. The more stringent the definition of failure-free survival, the better the results appear. Be careful. All that said, I am not against focal therapy, and I do offer it to my patients. I discuss the pros and cons in a balanced way, as balanced as I can, given the potential quality of life benefit of focal therapy. If a patient is willing to accept the trade-offs, then in my opinion, focal therapy for properly selected or optimally selected patients is a reasonable option, even if I do not consider it the standard of care. Thanks for your attention to this talk, and I look forward to seeing you soon.